everyone. This is actually a free session uh, regarding acute GA bleeding. This is mainly made to make your INA as a surgical gastroenterology preparation easy. So basically, this is a points which is collected from Sebastian, Shackelford, and some important points from the Blumberg. Am I audible? You can post your questions in the chat box, and straight away we'll go into the topic. And the first question is the false statement regarding GA bleeding. So we will discuss with a question answer session. Okay, rather than going like a theory part, we will go like a question answer session. And then is it very easy to grasp things. Okay, so the first question is false statement regarding GA bleeding. So the first option is upper GA bleed originates proximal to ligament of treats. Okay, UGA bleed is the most common form of GA bleeding. LGA bleed mostly from diverticular disease. Hepatic bleed is not included in UGA bleed. So the answer is obvious. It's a straightforward question. So ligament of Treats is a landmark. Proximal to the ligament of Treats is upper GA bleed. Distal to that is a lower GA bleed. The most common GA bleeding is upper GA bleed compared to lower GA bleed. And lower GA bleed, the most common cause is diverticular disease. Hepatic bleed, pancreatic bleed, and biliary tree bleed, everything is included in upper GA bleed. So option D is a false statement. So UGA bleed, most common causes peptic ulcer disease or esophageal varices. Pancreas, liver, biliary origin included in UGA bleed. So lower gastrointestinal bleeding is the most common causes are diverticular disease and angiodysplasia. So this is a question based on Sebastian. And second question is, systolic BP less than 90 millimeter mercury happens after -% of blood loss. Okay, this question actually taken from Sebastian. This is also present in Bailey also. Okay, so percentage of blood loss will cause the systolic BP less than 90 millimeter mercury. The options are 30 to 40%, 40 to 50%, 60 to 70%, and 80 to 90%. And the answer is, it is 30 to 40%. After 30 to 40% of blood loss only, the systolic BP will go down to less than 90 millimeter mercury. Okay. And third question is false statement among the following. So additional management priority includes liver function test. Okay. In UGA bleed or any gastrointestinal bleeding. So additional management priority includes liver function test or not. And second option is 1 fresh frozen plasma per 2 units of PRBC. This is the massive transfusion protocol in GA bleeding. That is the second option. Third option is about a landmark study. Villanova landmark study includes massively exsanguinating patients. Okay, this is a study mainly for the restrictive transfusion. Okay, so that includes massively exsanguinating patients. That is the third option. Fourth option is the hematocrit is the reliable indicator in acute severe bleed. Okay, so which is the false statement among the following? Actually, this is a kind of PGA kind of question. So there are two options are wrong in this. Option C and option D. So Villanova study about a restrictive transfusion. The threshold is only 7 gram per deciliter, the target, which excludes massively hemorrhagic patients. Okay, so the third option is wrong. Villanova landmark study includes massively exsanguinating patients is wrong. Actually, that excludes massively hemorrhagic patients. And fourth option, hematocrit, is not the reliable indicator as it took hours to dilute, makes fluid shift from decision. So the option D is also wrong. Hematocrit is not the reliable indicator in acute severe GA bleed. And this is a flowchart algorithm for the evaluation of acute GA hemorrhage. The first thing what we should do is a nasogastric tube lavage. Okay, that actually differentiate upper and lower GE bleed. If it is bilious, then lower GE bleed should be suspected. If it is a clear or blood-stained aspirate, then UGE bleed is a suspected one. So if we are suspecting UGE bleed, then the patient is hemodynamically stable or unstable. If the patient is stable, then we could go ahead with the other stigmata or history about cirrhosis or varices or alcohol history or chronic peptic ulcer disease history. Some other things we can have time to ask the patient. So if the patient is hemodynamically stable, okay, then if the patient is hemodynamically unstable despite resuscitation, yes, the patient is unstable, then go ahead with the variceal bleeding, balloon tamponade, or non-variceal bleeding. Straight away go into the operative room with the intraoperative angiogram. So these are the things we should do. The patient is unstable despite resuscitation. The patient is stable after resuscitation. Go ahead with the esophageal gastroenterologist, preferably within 12 hours rather than 24 hours. Okay. So if the esophageal gastroenterologist is non-diagnostic, then other options we should go ahead. Video capsule endoscopy, a deep endoscopy. So to rule out other etiologies or other sites of bleeding like small bowel, so RBC scan, Meckel scan, scintigraphy. These are the other modalities if esophagogastroduodenoscopy is non-diagnostic. So if the aspirate is bilious, we are suspecting lower GE bleed. Okay. If the patient is hemodynamically stable or unstable, if the patient is unstable despite resuscitation, then go ahead with surgery plus or minus with intraoperative angiography. That is the obvious one. The patient is unstable, go ahead to the operative room with intraoperative angiography. Okay. The patient is stable after resuscitation. So in LGE bleed, so there are two things. One is CT angiogram, other one is rapid bowel preparation and colonoscopy. Okay, CT angiography is another method where we could differentiate upper GE bleed and lower GE bleed, where the bleed is actually from. Okay, so the question number 4 is false statement about localization methods. The first thing option is nasogastric tube insertion is a first step. Okay, the second option is in stable patient, CT angiogram is a first choice in middle GE bleed. Okay, and third option is technetium labeled RBC scan can detect 0.3 ml per minute blood loss and can be repeated within 24 hours. That is about the RBC scan. And option D is precision of localization is not there in RBC scan. These are the options. Which one is false? First one is correct. NG tube insertion is C. So answer is C. So CT angiogram detects 0.3 ml per minute and RBC scan even it could detect 0.04 ml per minute blood loss. It could identify. Okay. And the other options are correct. Technetium, precision of localization is not there in RBC scan. There's no which quadrant it is there. It is bleeding. That we could identify by RBC scan. But that precise localization is not possible with the RBC scan. Okay. And the other thing is about video capsule endoscopy. So mainly for the small bowel bleed. If the patient is stable, we are suspecting small bowel bleed and non-diagnostic OGD scopy and colonoscopy, then go ahead with the video capsule endoscopy. That is a non-invasive one. So what are the risk factors for the capsule retention? Those are chronic NSIDs or tumors, Crohn's disease, small bowel radiotherapy or surgery. These are the causes of or risk factors for capsule retention, video capsule endoscopy. And the other things are factors associated with a positive capsule study. So these are the points given in the Sebastian. So male sex more than 60 years or hospitalization during the test performance. These are the risk factors associated with a positive capsule endoscopy. Okay. Then other options like push endoscopy, that is 60 to 70 centimeter distal to the ligament of treats, we could identify by push endoscopy. And second thing is double balloon enteroscopy. In that case, we could screen the entire small bowel, unlike push endoscopy, where we could only screen 60 to 70 centimeter distal to the ligament of treat. Okay, and double balloon enteroscopy, entire small bowel, entire small bowel entire small bowel could be screened in double balloon enteroscopy. And in case of altered anatomy, So device assisted endoscopy could be useful. Okay. The other things are intraoperative endoscopy. If everything is not identifying the source of bleeding, then the other thing is do an laparotomy, do an enterotomy, go ahead with the small caliber colonoscope or endoscope to identify the localize the bleeding site. That is the intraoperative endoscopy. The next option is about 24 years old male presented with hematemesis. Before esophagogastroduodenoscopy, all of the following done except before ogidoscopy if the patient comes with an hematemesis. So initial resuscitation, right? PPI is right. Erythromycin is it needed before ogidoscopy, esophagogastroduodenoscopy? So the answer is D. Yes, prokinetics erythromycin is also needed before ogidoscopy. That actually reduces the need of second ogidoscopy and reduce the amount of blood transfusion and length of hospital stay. This is based on a meta-analysis. So erythromycin is needed, PPA is also needed, and one more thing is initial resuscitation by securing two large bore cannula. Okay, so esophagogastroduodenoscopy should be done within 12 hours. So that is about the before ogidoscopy things. And this is a must-know tabular column from the Sabiston, from Sackford. Everyone, they are asking some questions directly or indirectly from this tabular column. The forest classification for endoscopic findings and rebleeding risk in peptic ulcer disease. This is actually based on the endoscopic finding. There are 6 grades are there. In grade 1, there are 2 subgrades. Grade 2, there are 3 subgrades, and grade 3. Based on the rebleeding risk, there is 3 high risk and 1 intermediate to low risk. Okay. In about the grade 1, that is actually active pulsatile bleeding. 1B is active non-pulsatile bleeding. And about 2, we can subclassify into A, 2B, and 2C. 2A is there is no bleeding, but vessel is visible. That is 2A. That is also having high risk. And about 2B, that is an adherent clot. So that is having intermediate risk. The clot dislodges, again bleeding will start. So that is having intermediate risk of rebleeding. And about 2C and 3, these things having actually low risk of rebleeding. Okay. And 2C, about 2C, the ulcer with black spot. And about grade 3, that is clean non-bleeding ulcer bed. Okay. That is also having very low risk of rebleeding. So this about question number 6 about rebleeding risk of the below endoscopic picture. First of all, what is this actually endoscopic picture showing? Which grade of forest classification? This is showing an adherent plot over the bleeding point. Okay. So this is a picture which is showing the 1A, 1B, 2A, 2B, 2C, and 3. So 2B actually is the 2B which is having rebleeding risk of 20 to 30%, which is having adherent clot. So this patient is having rebleeding risk of 20 to 30%. So basically we could remember this grade 2 by VCD player. Okay, non-bleeding visible vessel. V. C means clot. D means dot. So VCD. So grade 2 is VCD player. Okay, you know VCD player, right? So visible non-bleeding visible vessel is V. C is clot. D is dot. Okay. So ulcer with the black spot is a 2C. So VCD. You could memorize like this. So rebleeding risk, they could ask rebleeding risk of 2A, 2B or 1A. So 60 to 100% of rebleeding risk is there with the 1A active spotting. 50% rebleeding risk for active oozing without any non-pulsatile. Okay, active oozing is there, but there is no pulsatile bleeding. That is 1B having 50% risk. And 2A is non-bleeding, but visible vessel is there in the ulcer base. That is having 40 to 50% of rebleeding risk. And about 2B, what we saw in the previous slide, adherent clot is having 20 to 30% of rebleeding risk. And followed by that 7 to 10% in 2C. And 3, it is 3 to 5%. Okay. And about medical management in UGA bleed, we should avoid the NSAID use and SSRIs, selective serotonin reuptake inhibitors. And we should preferably use the COX-2 selective NSAIDs along with the PPA. And about the aspirin, for primary prevention, if we are using aspirin for the primary prevention from cardiac side, that could be stopped. Okay. But in case of secondary prevention, they are using aspirin cardiac side, then we should start aspirin again 1 to 7 days after bleeding stops. Okay. Then proton pump inhibitors before OGD actually reduce the risk category and intervention need. So if not given before OGD we should give bolus of 80 mg followed by 8 mg per hour. Okay. And the next question is about endoscopic management. False statement regarding endoscopic management. It is about the modalities we are using in endoscopy to control the bleeding. So hemoclips are less efficient than thermal methods. So first option. Second option is epinephrine injection alone increases the risk of rebleeding. That is the second option. And third option is initial hemostasis of epinephrine monotherapy is 100%. And fourth option is most commonly used is sclerosant injection therapy. The false statement is actually hemoclips are less efficient than thermal method is correct. Epinephrine injection alone increases the risk of rebleeding is also correct, because we should utilize the other modalities combined with epinephrine injection. Okay, but the initial hemostasis of epinephrine monotherapy is 100%, but rebleeding risk is very high with the epinephrine monotherapy. But fourth option is wrong. Most commonly used is not a sclerosant therapy. So sclerosant therapy is less attractive because of tissue damage. And epinephrine combined with the thermal methods to reduce the rebleed risk. In all four quadrants, we should instill 0.222 ml of epinephrine. So hemoclips take time to apply, or sometimes the first misplaced clip hinder the further clips. Okay, but marking for further imaging, the clip what we put inside could be used as a marker during angiography, CT angiography. Okay. The next question is about angiographic intervention. The false statement regarding angiographic intervention. Super selective embolization is preferred. Okay, this is the first option. Second option is gel foam, most commonly used. Third option is gel foam is a temporary agent. And fourth option is none of the above is false. All of the above are correct. What is the answer? So super selective embolization is preferred to prevent the bowel infarction. Okay, if there is a bleeding from left gastric artery, we should go ahead and super selectively, we should cannulate and we should embolize that particular artery, which is a reason for the bleeding. Second option is gel foam is most commonly used. Actually, it is a wrong option. So coil and polyvinyl alcohol is most commonly used method for the angiographic embolization. Okay, coils and polyvinyl alcohol. And option C is correct. Gel foam is a temporary agent. Okay, the vessel actually recanalizes after some time, after weeks to months. Okay. The next question is all of the following risk factors of rebleeding and failed endoscopy except. So these are the factors which is having high risk of rebleeding and the failure of endoscopy, except the bleeding is from the large ulcer more than 2 centimeter, or posterior duodenal ulcer, greater curvature ulcer, none of the above. So risk factors of rebleeding and failed endoscopy. So lesser curvature ulcer is the risk factor for the rebleeding and failed endoscopy than greater curvature ulcer. Okay. See, next thing is what are all the indications for surgery in GA hemorrhage? Okay. So thing is hemodynamic instability despite vigorous resuscitation. More than 6 units was transfused. Still the patient is having hemodynamic instability. That is an indication. So more than 6 units or up to 2 attempts of endoscopic hemostasis was failed. So shock associated with the recurrent hemorrhage. So per day exceeding 3 units of transfusion requirement. So 3, 6, 2, 3, 6. That's what we should remember. 2, 3, 6. What is 2? Up to 2 attempts of failed endoscopy. 3 units per day is required, or more than 6 units of transfusion. So still the patient is having hemodynamic instability. Then the next option is surgical management. So what is the surgical management for duodenal ulcer? So most common site is from the duodenal bulb. Okay. So then we should go ahead with the duodenotomy. Okay. So duodenopyloromyotomy. So then we should go ahead to look for the site of ulcer. If the anterior ulcer, we could ligate directly. That is a posterior ulcer. That is a U stitch. 3 stitches method is usually used. This is a picture showing that typical U stitch. That additional U stitch is placed to control small transverse pancreatic branches from the main vessel. Okay. So transverse pancreatic branches. So this is the additional U stitch is placed to control the bleeding from the small transverse pancreatic branches. So superior and inferior direction we should ligate, and another additional U stitch over the small transverse pancreatic branches that they could ask. Okay. And next thing is what we should do along with the surgery is pyloroplasty plus truncal vagotomy. So most common acid reducing surgery in bleeding. Okay. If the patient is stable enough, we should go ahead with the pyloroplasty plus truncal vagotomy along with the hemostasis, securing hemostasis. The next option is about Mallory waist tear. This is also the one of the reason for UGA bleed. So because of the partial thickness tear in the mucosa and submucosa of stomach. So usually happens near the GE junction over the lesser curvature. Actual history, usually the binge drinking from alcoholic and intense retching against unrelaxed cardia. So 90% the treatment is acid suppression and giving NPO. That is modality which will be successful for 90%. Sometimes it needs endoscopic therapy or angiographic embolization, but recurrence of bleeding is uncommon with the Mallory waist tear. Okay. The next thing is about an endoscopic picture, which is showing a patient with the UGE bleed. So this picture is showing a typical appearance of gastric antral vascular ectasia. So the typical appearance is watermelon appearance. So actually the dilated venules will give the appearance of streaks over the mucosa. Okay. So severe hemorrhage is uncommon. Usually the patient will present with chronic persistent iron deficiency anemia. The typical treatment is argon plasma coagulation. Okay. Argon laser plasma coagulation. They could ask APC is the treatment for GAVE, gastric antral vascular ectasia. Otherwise, if that is not controllable, then we should go ahead with the antrectomy. And this is another endoscopic picture of a patient with the UGE bleed. This patient could present with a massive GE bleed. Actually, this is a case of duodenopylation. Okay, this is basically a vascular malformation which is present in the mucosal aspect, usually in the lesser curvature, 6 cm from the GE junction. So erosion of the mucosa exposes the vessel. So it can occur anywhere in the GE tract, but most common site is lesser curvature. So there is a mucosal defect without ulcer. Okay, there is a mucosal defect without ulcer. So that defect will expose the underlying large artery. So there is a chance of massive bleed. Okay, in duodenopylation. This is spurting vessel from the duodenopylation because of the overlying mucosal erosion, exposing the submucosal large. So the treatment is by endoscopic therapy. The next thing, what is that? Variceal hemorrhage. The UGA bleed, one is non-variceal, the other one is variceal hemorrhage. Variceal hemorrhage usually happens if the portal pressure is more than 12 millimeter mercury to develop varices. Okay. So esophagogastroduodenoscopy every 2 years. If there is no varices, the patient is having a history of alcohol, the patient is proven cirrhosis, but there is no varices in endoscopy, we could follow the patient every 2 years with the ogidoscopy. The patient is having varices with a very grade 1. Okay, if grade 1, that means the full inflation, the varices will disappear in ogidoscopy. If grade 1, we could wait. Okay, we could wait without any additional prophylactic banding. We could follow the patient with the non-selective beta blockers. Annually, we should do the ogidoscopy. Patient is having grade 2 or grade 3 or grade 3 borderline, we should go ahead with the prophylactic banding. Okay, variceal ligation, because there is a high chance of bleeding, variceal bleeding is there. Okay, for that patient, we should go ahead with the non-selective beta blockers, as well as we should do the prophylactic banding. And during varicella hemorrhage, the goal is hemoglobin 7 to 8 grams, okay? And INR should be less than 2, and platelets should be more than 50,000. This is the goal or recommendations during that, resuscitation of varicella hemorrhage, okay? Because the increasing the hemoglobin will actually alters the hepatic venous pressure gradient, okay? So we should maintain this hemoglobin 7 to 8 gram and INR less than 2, platelets more than 50,000. And antibiotics is also important in case of varicella hemorrhage because those patients are at high risk for SBP, hepatic encephalopathy, following a bleeding. Okay, then we should start antibiotics, IV ceftriaxone or oral fluoroquinolones is recommended. Okay, based on Savastin. And treatment modalities are banding for esophageal varices, grade 3 or bleeding esophageal varices. And the glue injection is mainly used for the gastric fundal varices. And the next thing is about Sengstaken Blackmore tube that is having gastric balloon as well as esophageal balloon. So that is to bridge or to maintain the hemostasis for a particular time, where we should shift the patient to. Uh, provisions having endoscopic, facilities. Okay, for that first we should inflate the gastric balloon across the OG junction, and other thing is about esophageal balloon. So we should deflate every 24 hours, okay, to prevent the pressure necrosis. And other these varicella hemorrhage and other procedures which is mainly used for varicella hemorrhage, Sugira procedure, Fugawa, all other things I'll discuss in the next session. And mainly, our motto for this crash course is to make questions to make all points of Sebastian Shackelford or some tables from Blumgott at one place and make it as a question, and we'll discuss that same topic along with that question. Okay, preferably it references your preparation, and I hope I discussed something about UG bleed, and the most important thing is about this forest classification. Okay, and I hope I give some points for your refreshment of preparation, and keep stay tuned with our group or YouTube link to get more updates, and try to join in our classes. Okay, so we are planning for daily based classes or live interactive sessions, weekly at least 3 classes to cover all the important high yield topics from the previous year questions. Okay, actually UG bleed they are not asking much from the UG bleed, even rock hard scoring they are not asking much. Okay, they are asking for classification or what is the next step, likewise they are asking. Okay, I think that rebleeding risk they could ask this time in April, and try to enroll for our classes to get more. Revision of high yield topics, and this is the end of the session. I think. Do you have any doubts? So adherent clot is okay. Adherent clot, yes, that is a yeah option. That is the answer. Adherent clot. So picture is showing adherent clot. I think everyone could answer this, but rebleeding risk we should memorize. Okay, if for adherent clot it is around 20 to 30%. Okay, we should thorough about this rebleeding risk also a bit. Everyone knows this classification, so we should memorize this rebleeding risk of each and every classification. Okay, do you have any doubts? And more things about variceal, surgery, sun surgeries, and Sugira procedures. Everything I'll discuss in the next session. Do you have any doubts? And we are planning for one quiz session, Kahoot session. I will share the link in WhatsApp. Okay. We'll have some 10 minutes of Kahoot session every day, about 10 questions. So everyone can join, and they could participate in that quiz. We are planning for separate quiz session each day for paid subscribers also. So try to stay tuned in our WhatsApp group. Try to enroll for our upcoming classes. So which is scheduled. We already posted our schedule in the WhatsApp group. Any other questions? And thank you, and stay tuned for the upcoming classes, and try to enroll for getting more in-depth knowledge about because we are planning for a separate session for Sackle tables. We are going to give the, all Sackle tables, Blumgott tables at one place, which is very important or previously asked. So I hope that crash course will be meant for everyone. Which actually diehard, aspirants of INASs who is preparing for more than one time, two times. Okay, definitely we'll give which is needed. Okay, now important Blumgott tables, important Sackle tables at one place, which is very much useful for you to revise at last minute. Okay, I hope you did something about UGA play. So much everyone who participated.